Hi, everyone. This is Samira Daswani, the host of the podcast, The Patient from Hell. I have one of my favorite people in this entire world with us today, Janice Cowden. Thank you for being with us.
Thank you for having me. It's such an honor.
Oh, you always make me feel so nice. Janice, I
It's
think you
true.
have to start. I think I'm just going to be laughing on this episode, guys. I'm just gonna fair warning to all listeners. Janice, should we start with your story? Because your
We
story is just one of the most remarkable ones I've heard in a long time. So
It is very different, and I wish it was a more common story. So I was diagnosed early stage with triple negative breast cancer in 2011, so almost 13 years ago. And then 5 years after my early stage diagnosis, I was diagnosed with stage four metastatic triple negative breast cancer, which is kind of unusual in and of itself. Most of the time, if triple negative is going to reoccur, usually happens within the first 2 to 3 years. So because I never do anything according to rules and by the book, I had to be different. And, my oncologist and I, it was at a routine appointment. And we were sort of in that celebration mode of, hey, we got to 5 years. Whereas with other types of breast cancer, like hormone positive or HER2 positive, after 5 years, that risk of recurrence really doesn't go down. It either kind of stays steady or might even rise over time. With hormone positive, you could have a metastatic recurrence 10, 20, 30 years afterwards. The risk actually starts going down with triple negative. So those who are early stage triple negative get to that 5 year mark and you're like, woohoo, made it. Um, and that's sort of how my oncologist approached it. But I was having some bone pain and joint pain that was, more than just the typical arthritic type pains. And I had done my research, surprise, surprise, prior to the appointment. And I had started a bone strengthening agent, Prolia, about a year before that appointment. And I read that one of the most common side effects was significant bone and joint pain. And I thought, well, that's it. So my intention at that appointment was to tell him, hey, I don't want to take this drug anymore because it's, practically disabling me. I mean, getting in and out of a car was painful. Everything I did was painful. I couldn't walk without limping. And so, thankfully, he was very proactive. And he said, you know what? He goes, you're at 5 years. I really don't expect anything, but let's just do a PET scan to make sure. And mentioned that, he just wanted to rule out that he didn't have bone metastases from triple negative. So I go into the PET scan, reassured that, hey, this is probably nothing because I'm 5 years out and he was in a celebratory mood and so was I. So it was quite a shock when he called me a few days later and said, I need you to come in so we can discuss the results of your PET scan. And so at that appointment, my husband and I went in, sitting there. He pulls, he sits down on his little stool in the exam room, comes up knee to knee to me, takes my hands. He has tears in his eyes. And he said, I'm so sorry, but you have a recurrence of your breast cancer. I'm fairly certain it looks like you have stage four metastatic breast cancer. We're going to do a biopsy of a subpectoral node just to confirm that that's what it is. But he said, I'm fairly certain according to the PET scan results. So did the biopsy and sure enough, it was confirmed that it was stage four, triple negative. So here's where the real uniqueness of my story comes in. We talked about treatment options, and at the time, there was no targeted therapy for triple negative breast cancer. So it was, which chemotherapy do you want to use? And he decided, because I was, even though we didn't call it that at the time, and this is something that I learned after, a couple of years after my diagnosis, I was really what's called oligometastatic breast cancer, which means I had very limited metastases. Ended up having like 4 lymph nodes. One of them was a distant on the opposite side of my original breast cancer, which is what actually made me stage four. And so I had very low burden of disease, but he said, I want to treat this aggressively. We're going to do adriamycin, Cytoxan chemotherapy. We'll do a scan after 4 rounds and we'll see where we're at. And so, as much of a shock to both of us, when I had that PET scan done in November of 2016, there was no evidence of disease. So we
What?
originally talked about following the AC. We were either going to do 4 rounds or 6 rounds of AC chemo and following that with carboplatin. And he said, I really don't want to put you on carboplatin at this time because I don't see anything to treat. And that made me feel wildly uncomfortable without a safety net, thinking he's just not going to treat me. So we're just going to sit around and wait for this disease to rear its ugly head again. And so we talked a little bit more. I had a consult with my radiation oncologist and we decided to do radiation. So I had 15 rounds of radiation about a month and a half later. And then we scanned again a month after I completed radiation, still no evidence of disease. So, of course, again, didn't want to put me on chemotherapy when there was no evidence of disease to treat. So we said, oh, let's just scan you every 2 to 3 months. And so that first year was incredibly stressful. Talk about, scanxiety, and it was like just waiting for the shoe to drop because triple negative is such an aggressive subtype of breast cancer that I don't think neither he or I were expecting me to continue having no evidence of disease. We were just sort of waiting for it to return and then make the decision, what do we try next? So that first year, scans every 2 to 3 months. They were all NED, which is no evidence of disease. Um, and then I'm now at 8 years this month out from my metastatic triple negative diagnosis. For a disease, and I don't believe that we are statistics or that we should really follow the statistical averages for things, but they're there. So the median overall survival for metastatic triple negative is still not beyond 2 years, really, at this point in time. So to be 8 years out and to still have no evidence of disease, um, yeah, it's very different. That makes my story very, very different. There are others I know who are in that same category, but not very many. In fact, I got second opinion. I got 4 second opinions because I wasn't comfortable with the idea of just waiting for my disease to progress and not do anything about it. So, I went to 4 different NCI designated cancer centers and got second opinions. I'm an overachiever like that.
Uh-huh.
And
That's
and I loved the oncologist. My husband and I both loved the oncologist that I saw at MD Anderson. So we stuck with her. And, she's always sort of told me you're in about a 1 to 2% category of those with metastatic breast cancer. So it really is unusual. Um, it's not that it can't ever happen. We don't use the word cured. We don't use the word remission. We just say that I have continued no evidence of disease. It would probably be unusual at this point in time for to have progression, but I do know others who have had progression with the exact same subtype of my disease more than 10 years out. So we never say never. We just sort of, but I have spread my scans out. My scans are now almost a year apart, which is nice. Um, so yeah, that's basically my story.
Janice, the irony is I know you, I know your story, and I think I have 15 questions.
Ask away. I will try my best to answer.
Can we go all the way back up? I'm going to go all the way back up, okay? 2011,
hmm
you get diagnosed early stage TNBC. What are you doing outside of like life as a patient?
Since 2011, or what was I doing outside of?
Doing then? Like,
Oh,
where were you
well,
working? what like what was
I
Janice 11 before cancer hits?
Oh, I've been a lot of things. I wear a lot of different hats, but originally, my career was as a nurse. Never worked in oncology. I always primarily worked in pediatrics for the majority of my career, and not in pediatric oncology. So I had zero oncology experience. And so once I retired from that, I did work as a pharmaceutical sales rep for a few years just to kind of see if I liked that. That was, it was, I loved our pharmaceutical reps when I worked the last part of my career. I actually worked in a private practice for a pediatrician. And it was wonderful because it was just getting to see the same people over and over again, unlike working in a hospital where patients come and they go and you don't really get to establish relationships. I worked at this practice for 13 years and it was wonderful. He decided, the only reason I retired is he decided to go back into ER medicine. So he closed his practice. And so we had a decision to make, did we want to look for work elsewhere? That's when I went into pharmaceutical sales. I had interviewed for a position and I didn't really think I would get it because I had no background in that. And so I was shocked when I got it, pleasantly surprised. And I enjoyed it. Mine was a part-time position, so I worked about 24 hours a week. I enjoyed it, not as much as being a nurse, but it's very different being on one side of that gate versus dealing with the gatekeepers when you are, a drug rep, because they generally don't like you and they get tired of seeing drug reps come in their office multiple times per day. So I I can understand that having been on the other side of that gate. Um, but it was interesting. So, and I did, dabbled in other things, but then I decided to go back to school because I love learning. So I thought, well, I think I'll go back to school. So I took some classes at community college. I did some classes at University of Dayton when we were still living in Ohio. And then we moved to Florida in 2006. And I decided that I would uh, go to University of Central Florida in Orlando, UCF. So I got a degree in interdisciplinary studies, which I'd never heard of before, but it was fun. It was
Wait, what did you study? What were the disciplines?
The disciplines were, well, health sciences. So I wanted something that would be easy. That one came easy. Um, Health sciences. I had to, my goal was to get out with a 4.0 GPA. So I had to do at least one thing that was easy. So it was communication, um, and health sciences and sociology.
Wow.
Yeah, so
How
it's kind
old
of
were
like
you?
having, how old was I?
Yeah.
I was, let me think here. I was 48 when I took my first community college class. Now, we moved in the interim. And when I started out, I just started with one class because I didn't even know if my brain would be able to, absorb and retain. So so I did very well with my one class. Then I bumped it up to two classes and three, and so on and so forth. So over the years, and then we moved in the meantime. So I actually went full time for a little over a year to get my degree at UCF, and it was a little stressful, doing 12 to 15 credit hours, but it was fun too because I was competing with myself to get that perfect GPA. But I said I'm crazy.
I love it. It's just it's so it's very refreshing.
Yeah. So I was 52 when I graduated with my degree in interdisciplinary studies. Yeah.
Jack, I'm gonna have to send this episode to my mom. No, I'm very serious. I'm completely serious. She has been talking about going back to school for a very long time, and she's always been very nervous about it. And it's I think it takes a special type of courage to do that.
It
And from
does.
here, you know, I'm
No,
going
it
for
really
it.
does. To be a non-traditional student sitting in a classroom full of 18 to 20 somethings, it took me a while to get over that. The community college was a little different because there were more people my age. But when I went to classes at like University of Dayton and UCF, I was really the only old person in those classes. And what I learned was you just sit in the front of the classroom because none of the kids want to sit up front. And they're sitting there, clicking on their phones and doing things, which was distracting for me. And the older you get, the less you are capable of multitasking, I have found, or at least me. And so it was distracting for me, and I was afraid it was going to make me, mess up my perfect GPA. So I just sat in the front of the classroom in every class, and then I didn't have to worry about it. And I took copious notes, which none of them were doing, but I didn't have to see what everybody else was doing. And so it made me feel more comfortable. And after a couple years of that, you get used to it, and you no longer think about um, being a non-traditional student. You don't really care anymore. But I'm glad I did it. When I first started doing it, our daughter was in college at the time, and our son was in high school. And so by the time he got into college and our daughter graduated, I was like, that was really fun because I would, hear about all the things they were doing in college. And I thought, I don't need that college campus experience again. I just need the learning experience again. And I appreciated it so much more as an older adult than I did when I was younger. When you're younger, there are other reasons to go to college than just getting your education.
Talking to a nerd, Dennis. My
Well,
goodness.
maybe
I don't know what you're talking about.
maybe not for everybody, but there were for me. So anyway, so that's what I was doing. And actually, when I was diagnosed early stage in 2011, it was a really odd time because my husband, he had always said he was going to retire at 55. That's what he did. So he retired. We sold our house, bought another house, and I was diagnosed with stage 1 breast cancer within a 3-week time frame. And that was based on my routine annual mammogram. And I had found a lump a few months before that mammogram. It was tiny, um, and no history of breast cancer in my family. So I didn't think too much about it. And I'd always had dense breasts and calcifications and all of that. So I just thought, it's just one of those things. But yeah, that was a very busy time. So we got ourselves moved out of the house we sold and into the house we bought, and I started treatment. And so that's what we did for our first 6 months of retirement was surgery, treatment, doctor appointments.
Great.
Sure not what my husband was thinking of when he said, "Hey, I'm going to retire." And so, so
I didn't know that about you. Our stories in that respect are actually very similar. I got
really,
diagnosed. I got diagnosed Jan 2020, so not retirement. Sorry, no, I'm not there. Kind of far from that right now. But my then boyfriend and I had just moved in together, and we were living in San Francisco. I had gotten a new job. We were gonna move from San Francisco to Redwood City, so we had this like not closing a house, opening a house, but like yeah, still moving. Moving in for the first time together.
mm,
New job, moving in, got diagnosed all in the span of like 10 days. And I remember, the formal diagnosis comes, you do the biopsy, the path comes out, the doc's talking to you about the treatment plan. And it was like Friday, we got the like final, like, you will have chemo kind of news. And Saturday, we had movers coming.
oh,
And we were like, okay, you know what? Let's go out for a celebratory drink and a dinner. And I was like, celebratory, sure. you know,
what are we celebrating?
not entirely sure about that, but let's go out to dinner. So I remember going to this like dinner spot and fainted a couple of times. And I remember so my like he's my boyfriend that I've been together a year and a half, and he's like holding me up, trying to get a cab, and the cab like sees me having like fainted, thinking that like it's a young person who's fainted at a bar, like not what was happening. It was, medical stuff. But the driver just drives off, like kind of like, I'm not dealing with these two people. And I just remember, like, I in my head I was like, I am yelling, being like, I have cancer. And apparently I didn't yell. Apparently I just like mouthed it out. So only my boyfriend, now husband, heard it. And he just looks at me and he goes, huh, that was the first time you acknowledged it. And I was like, great. Required me to faint a cab driver to drive off, not want to deal with me, I guess, to, actually say those words out loud. And it was just, yeah, and then we moved. And then my
Yeah.
parents showed up and moved in with us because, without them, I wouldn't have survived. But, my parents moved in with us and we had just moved in together. So it was
Now that's,
not
yeah,
exactly.
that can be a very trying start to a new relationship.
We made it. We're married.
Yes,
Yeah.
you did. Congratulations.
Thank you. Thank you. We got through one chapter.
Absolutely. So that's where I was at my original diagnosis.
Okay, I have more questions for you. So you're a nurse. Well, back then you were a nurse, but you clearly know a lot about oncology. How did you get here? How did you learn? How did you understand all of these terms that you may or may not have been familiar with? How do you keep updated with the phenomenal progress we're making in oncology? Like how have you done that?
It is a steep learning curve. And I did a lot of research when I was early stage, but I wasn't connected in the breast cancer community. Like I wasn't in any support groups. I didn't connect with anybody on social media. Um, I just sort of went on my own, did my own thing, researched, because I knew how to research. So I basically did that on my own. And when I was diagnosed metastatic, I look back now and I think, how did I not read the statistical average that up to 30% of those diagnosed with early stage breast cancer will have a metastatic recurrence? I didn't know that. And that's not something that oncologists, as a rule, talk to patients about. It could be that they don't want to incite fear, but in my opinion, that is a knowledge gap that we really need to know. I know there are some patients that don't want to know. People have all different desires on how much and what it is they want to know. But I think just to know, I honestly thought it would happen sequentially. I thought, well, you don't go from stage 1 to stage 4. If I'm going to have a recurrence, it's going to be stage 2, or it's going to be a local recurrence before it's a metastatic recurrence. So that I sort of tried myself a little bit on not being a little bit more um, astute in researching and finding that out on my own. But guess what? I'm not alone. Most people that are diagnosed metastatic as a recurrence didn't know that either. So
Huh.
once I was diagnosed metastatic, I dug back into the research and didn't connect again on social media with anybody. Didn't even think about it. I was on social media, just didn't think about using that as a resource. So I had been using Living Beyond Breast Cancer's website since my early stage diagnosis, just for information resources. It was one of several that I used. And I happened to go on there and see that they had a metastatic breast cancer conference in April of every year. And they had an advocacy training program called Hear My Voice. So I thought, well, I don't really know what that means to be an advocate, but I'm going to apply. I mean, I thought, what do I have to lose? The worst that can happen is they say no, and then maybe I just go to the conference and attend and learn. But I got accepted. And so I was about 10 months out from my diagnosis when I went to my first ever breast cancer conference, which is their NBC conference. So I did that all at the same time. We had our Hear My Voice training during the conference. And, you walk in, there's a ballroom with like 400 people. And the majority of them are living with metastatic breast cancer. And here I walk in, never having met anyone with metastatic breast cancer before, not really knowing that there were MBC support groups on social media. That opened my mind. It opened doors. I got connected. And I think that's really, when you talk about how do you learn, it is a matter of immersing yourself and also being open to understanding that those connections that you make with people who have metastatic breast cancer, there's going to be grief, there's going to be loss, a lot of it. But in the end, uh, those relationships are so valuable and so worth it. I learn from other patients. I learn from attending scientific conferences. I attend a lot of webinars. I I know a lot of people who have no healthcare background, no science background, who are brilliant. They know way more than I do. And so I don't think that's required. I hear it a lot when people say, "Oh, well, you were a nurse, so that makes it easy for you." In some ways, yes, I understand some of the biology. I understand some terminology that maybe someone who doesn't have any background might not understand. But guess what? It goes back to that theory that I learned in communication class. The more you hear it, the the more likely you are to retain it. And that's really what happens is you get connected with people who have like interests. Like most of my advocate friends love the science as well. So, it's like your peer group. They become your peer group. And so you hang with these people, you learn from them, you get connected, in areas that you didn't know, you hear about conferences you didn't know about, you get involved in organizations, and that furthers your learning. And I think for me, it's always been, I truly am a person that believes that knowledge is power. So I never stayed away from learning, even the hard stuff, looking at those. When I was diagnosed, the median overall survival for metastatic triple negative was about 9 to 15 months. And so when you're diagnosed with that and you're reading these things, some people might turn away because it's just too overwhelming. For me, it's like, I gotta know.
Hmm. On that, you know me well enough to know that I fully believe knowledge is power, and fully believe that the whole point of this podcast and all the work we do is to get patients and families access to the right knowledge at the right time, because it's very overwhelming. And I, like you, get the same thing of like, oh yeah, you're a bioengineer, therefore. I'm like, well, yes, but you don't have a choice when you
You
get to
don't.
you have
And
to.
I think you have to have a little bit of a passion to learn it, whether you have, any background knowledge or not. There needs to be some level of passion that you have this passion that you just want to know. You want to continue learning. And clearly being an older adult going to college, I do consider myself a lifelong learner. So,
I love that so much. I love that. Okay, I told you about the rapid fire, our
yes.
little new experiment. I had come in prepared for, I don't know, 10 questions, and in talking to you, I told you I have a lot more. Sorry.
No,
Just
ask away.
so, okay, so we're going to do this. I'm going to ask you a series of like, what is questions? And if you want to just do a quick 30-second like definition, that would be great. And then we'll come back to your story after our little rapid fire section.
Absolutely.
All
Let's
right.
do it.
Okay. All right. What is an advocate?
An advocate is someone who seeks to better inform themselves and better inform their community. It's a whole lot of different things. And there's all types of different advocates out there. Depends. It's somebody who really speaks up for and promotes something. That wasn't a very good definition, but that's all I've got.
Okay. We're going to do one more of this. What is a patient advocate?
A patient advocate is someone who either ensures that they are getting the quality of care and knowledge that they need for their own self, or they help other patients, or they do both.
Awesome. What's MBC?
MBC is metastatic breast cancer. Metastatic breast cancer is stage 4, which means it has spread from the breast to distant sites such as lung, brain, bones, liver, sometimes distant lymph nodes.
What is TNBC?
TNBC is triple negative breast cancer. Basically, it means that the cancer is not fueled by any of the typical biomarkers such as estrogen, progesterone, and HER2.
What's a lymph node?
A lymph node, oh goodness, you're really challenging me. So a lymph
Sorry.
node is basically part of our immune system that filters out all of the trash and the junk in your body. Could be viruses, tries to filter out cancer. It's kind of a clearinghouse.
I love that. It's actually a very nice definition. This is why I challenge you. Ha! 4.0 GPA. Janice, I'll get the overachievers to answer these questions. All right. What's Metaviver?
Metafiber is a nonprofit organization whose mission is, there are a couple of different missions, but the most important is that it funds metastatic research for metastatic breast cancer only. So basically, we fund grants, research grants. And we also do peer-to-peer support, and we have other programs that we do as well. But the primary mission is to fund research for metastatic breast cancer.
What's oligometastatic?
Oligometastatic is a term that basically means very few lesions, and the definition has not been standardized, but it in general is about 1 to 5 metastatic lesions in maybe 1 or 2 body systems.
What's overall survival?
Overall survival is an average, basically, of how long a person is expected to live with a certain condition or disease.
What's a recurrence rate?
Recurrence rate is the percentage of people that are at risk to have a recurrence of a disease such as breast cancer.
What's distant recurrence?
Distant recurrence is recurrence of, let's say for breast cancer, distant recurrence means that you have recurrence of your breast cancer that has gone beyond the local and regional lymph nodes, such as in the axilla or the armpit or in the internal mammary chain.
I think you answered my next one. We're going to do it. What's local recurrence?
Local recurrence is a recurrence of your disease either in the same area as the primary site or still within that local regional area.
What is scanxiety?
Scanxiety is a horrific, stressful period of when you are due to have scans or imaging scans, whether it be a PET scan, CT scan, bone scan, whatever kind of imaging scan it is. It can be either leading up to anxiety, leading up to having the test done, or for me, it's really the amount of stress and emotion that occurs between having had the scan done and waiting to get the results. It's anxiety.
What's NED?
NED stands for no evidence of disease, which means on imaging, no evidence of the disease that was being treated can be seen. Doesn't mean it doesn't exist. Could be microscopic, but there's no imaging or there's no evidence on imaging scans.
What is SABCS?
That is the San Antonio Breast Cancer Symposium, which is an annual scientific breast cancer conference held in San Antonio, Texas.
That Janice loves.
That I do love.
What's ASCO?
ASCO is the American Society of Clinical Oncology. They have many different, it's an organization that does a lot of different things. For instance, I am a patient advocate on an ASCO led CDK4/6 dosing study. So they do clinical research, they do guidelines, they do all kinds of things. But ASCO also has an annual meeting, which is held in Chicago every year in late May or early June. And it is for all cancers. It's a scientific conference that is for all cancers, not just breast cancer.
What's ADC?
ADC is an antibody drug conjugate. So that is a drug class which is newer for breast cancer, metastatic breast cancer. And it basically is a drug that's kind of a three-part drug. There's the antibody that finds the receptor on the cancer cell, there's the linker that attaches it, and there is a payload that is included in there that is released once it has internalized into the cancer cell.
What's IO? Immunotherapy. Sorry.
Oh,
Sorry.
like
We're gonna do that. What is immunotherapy?
Immunotherapy is a targeted therapy for breast cancer that basically uses your own natural immune system to attack cancer cells.
What are checkpoint inhibitors?
Checkpoint inhibitors are, oh gosh, how am I going to explain this one? Are we talking just about CDK4/6s, basically?
We have next question, so we can go to that one. What's a
Okay.
CDK4/6?
You know what? I don't really remember what the C and D, but I know that the K is for kinase. But a CDK4/6 inhibitor, which there are actually other CDK inhibitors, what they do is they work on preventing the cancer cells from dividing and multiplying at a certain phase of the cell cycle division, which
This
could
is
be
so
cell
good.
division kind of.
You're so good at this. Oh my god. Okay. What's median survival?
Median survival, it's not average, and I always get tripped up on this. I know it's not median. I mean, it's not the average survival. It's not like 50-50. I can never remember exactly what median means, but when we talk about median progression-free survival or median overall survival in relation to a clinical trial, it's sort of that line where I guess the majority of patients fall into, like, if your median progression free survival is 6.4 months, that was where most people, that's how long they went without having progression of disease. Or median overall survival, same thing. That is when, the majority of people were alive at that time frame, I think.
Yep.
I think.
I think you're right. PFS. What is PFS?
Progression free survival basically is the time frame from when your disease is being treated until you progress. So with metastatic breast cancer, if you're being treated, you're diagnosed, you're put on a drug, it's the expected amount of time, I guess, or the time that is found in a clinical trial before the majority of people have progression of their disease. So it's that time frame in between while your disease is stabilized, or maybe you have no evidence of disease for that amount of time.
What is DFS?
That is disease-free survival, or sometimes you'll see DFI, which is the disease-free interval, and that can be the time frame, like for me, between when my early stage was diagnosed, I had a disease-free interval of 5 years between when I last was diagnosed with early stage and between my metastatic recurrence.
I think that's all the questions I have for you. Is there a question I should be asking you?
No, I can't think of any.
Okay. All right. So I'm going to try and wrap up our time together by asking you two more things, broader, not
Sure.
rapid fire. It's whatever you want. When you were talking, there was something that struck me. And what struck me was two things. I heard you describe you got the metastatic diagnosis. You had the few rounds of AC, and then the scan was clean, and you were uncomfortable. And if you're okay with it, I'd love to talk about that because I think that's a part of the cancer narrative that people do not understand.
Right.
Because when a scan is clean, there's this expectation of celebration. There's this expectation that you should be happy. You should be glad. And yet, I fully understand that moment of, yes, but. And if you don't mind talking about that, Janice, I think that would be super helpful.
I don't mind at all. For one thing, I think, when you're early stage, and scanning was not part of my early stage standard of care. I mean, once I was done, I
Oh,
didn't get scans. I had mammograms, but other than that, I didn't get scans. And it's not necessarily standard of care after early stage breast cancer to get any kind of scans done. Um, but with the metastatic, it's incurable but treatable. I try not to use the word terminal because I think that's a joy stealer. Um, but with metastatic breast cancer, and I think when you're first diagnosed, or you learn that it's incurable but treatable. So you don't expect to have, it's great to have a clean scan, but one of the things that you learn is that that can be very fleeting. And a lot of people will reach NED or NEAD, and it's not expected to last with metastatic breast cancer. So my discomfort was mainly because when we originally set up the treatment care plan, he had told me we were going from AC and then we would follow that with carboplatin. And we didn't talk about if your scans are clean or if they're not clean. That was just the treatment plan. So I couldn't understand, you know, I was I was fearful. I mean, that is fear. It's fear of, but wait, everybody else with metastatic breast cancer stays on treatment for life. What do you mean you're not going to keep me on something? Because to me, it was a matter of preventing that progression of disease. And I felt like it was a safety net that I didn't have. So, yeah, that was quite uncomfortable for me. And uncomfortable enough to the point where I did get those second opinions because I thought, what if I'm not getting standard of care? What if I should be on something? And they all confirmed that his plan was what they would do too. I also wanted the second opinions because I really believed I was stage 3C and not stage 4. So I really did. And it wasn't denial. It's just that, you know, the one hilar node that was the contralateral node, I just didn't realize that just that one little tiny node could make me stage 4 just because it was on the opposite side of my breast cancer. But I also got confirmed that it was stage 4 by all 4 of my second opinions. But yeah, the fear is, it's like early stage. I think the first 2 years after I completed treatment for stage 1 triple negative, I had an enormous amount of fear of recurrence. It was almost paralyzing at times. And at that time, there was no, the early stage triple negative now, they will put them on some type of maintenance therapy, often after they finish their treatment of Xeloda, sometimes immunotherapy. There was nothing like that. It was just, and I wasn't getting scanned. So I think once you get a breast cancer diagnosis, that fear doesn't really ever leave. I'm much more comfortable now being 8 years out, but yeah, it was stressful.
I definitely relate. I definitely relate. I don't remember feeling scared when I got diagnosed. People would ask me, they're like, "Are you scared?" I was like, "No, not really. Like, early stage, at least today." And I was triple positive, so not triple negative. The outcomes are good. like they're good outcomes. Like the stats are actually in your favor. And I don't remember being scared at diagnosis. If you ask me today, oh my God, ha ha ha. Ha. It's
The
like,
more you know.
oh my God. I'm also one of the people who has really, really looked very carefully at recurrence rates. And ha ha ha.
Yeah.
Knowledge is power, and then knowledge can be
Knowledge,
sacrificed.
ignorance is bliss. Sometimes, I mean, that is true. I will say that I was scared at my stage one diagnosis because I had known another pharmaceutical rep who was diagnosed triple negative de novo, and she lived 9 months. And so that was the only thing I knew about triple negative breast cancer, really, other than what I researched on my own. And stage one, I didn't know that I wouldn't die from early stage breast cancer. And I certainly didn't know much about recurrence rates either.
Okay, I'm going to ask you. I was not planning on asking you this, but I'm going to ask you. And if you don't want to talk about it, tell me and we don't talk about it, okay?
Okay.
Uh, One thing I struggle with is the more and more I get involved with the cancer community, the more friends you make. And the friends
Yes.
you make in the cancer community are just, they're special. Like it's a special relationship. They also may not live very long. So my question for you, if you're willing to talk about it, is how do you grapple with that? How do you grapple with having these incredibly deep relationships with people who statistically don't have the best odds? And then sometimes, even if their odds are in their favor, they don't fall into the median band, right? And you end up losing people. So that's my topic.
No, I'm happy to talk about that because it is, I think it's something, especially those who are newer to their diagnosis or those who are new into advocacy. Um, I think it takes a while to really wrap your brain around that. And I will tell you that when I did the Hear My Voice training, we lost our first classmate 3 weeks after our training. We lost five more within the next 6 months. And I had no idea how to deal with that. And most of my classmates through the Hear My Voice class didn't know either. And we were so, um, I couldn't even think about advocacy because I was grieving these people that I had just met. And I didn't know what it was like to get to know people so quickly and so deeply. You form those friendships very, very deeply. Um, and then have that much loss, one on top of another. And so I give LBBC a lot of credit because what they did is they saw that we were struggling and we were supposed to have like quarterly calls, check-in calls for our class. And they started doing monthly calls to check in with us and where we could just talk. We could talk about it. So that was very helpful. But I will say the first 2 years that I was in advocacy, each loss sort of threatened to paralyze me and make me want to walk away because it's like losing your best friend over and over and over again. And it's very difficult. So I finally figured out a way to, I guess, channel that grief into productivity. And that was through advocacy. And it was a mindset that I had to develop on my own. And the way I started looking at it is they have no voice anymore. And most of my friends are very powerful, very wonderful advocates. The friends I've lost were wonderful advocates. And I thought, how unfair is that for them to die, lose their voice? They no longer have a voice to advocate. It's my job. It's my role because I've been given a gift of time. So guess what? I use that gift of time and I channel that grief into productivity through advocacy. And that's what gets me through. It doesn't make the losses hurt any less. They are, in fact, this past year, the past 12 months, probably 18 months, have been horrible. I've lost so many friends that I had known, advocates that I met years ago, years and years ago. And I guess they do so well until they don't. And some of them, the end came on very quickly for some. Others we watched, and you have that anticipatory grief where someone's going to die, they're failing. Sometimes it happens quickly, sometimes it doesn't. And when it happens very quickly, you need a moment to catch your breath. I think everybody has to deal with it differently, but that's the only thing that gets me through. It's not that I'm numb to it or that it doesn't bother me, but I feel like I owe them. I owe them my time to continue advocating on their behalf as part of their legacy. So that's what gets me through.
I have tears in my eyes right now.
Oh, I'm sorry.
This is the first.
Oh, I'm so sorry I made you cry.
No. I don't think you made me cry. I think I have tears because it's so true.
It is. And it's hard in the past 6 to 8 months. Many of my very, very close friends have had progression of disease. And some of them are, they're beyond their fifth, sixth line of treatment. And that plays into that anticipatory grief. I mean, that, we have a finite number of treatment lines, and with each line, it works for less time typically. So yeah, it's hard. It's really hard. And I don't think there have been times when I've wanted to walk away because it's just too painful. It's too hurtful. But then I can't. And I won't.
I think you just summarized our podcast. No, I think you really did.
Thank you.
I think that statement of like I can and I won't. I think it captures the work, the passion, the mission. One of the many reasons I so admire you and love you, and I see the work you do for the community, and I think we're better for it. And Janice, thank you. Thank you for being a part of the community. Thank you for leading the community. Thank you for being a guest on this episode, and thank you for teaching me everything you do, because you really do. You teach me a lot, so thank you.
And thank you. That learning is bi-directional. I learn a lot from you, and I'm so grateful to know you.
Likewise. Thank you.
Thank you.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.